Professor, please tell us what biodigital twins are.
Now move on from artificial intelligence applied to surgery to biodigital twin. So as you know, this is old concept, old definition that the digital twin is a virtual model that represents a real world entity. So it means that this was already defined and applied in heavy industries, especially on the NASA, because they try to duplicate the engine, and so this was extremely important because if there are some failures inside the engine, they can correct the mistake in the lab. So obviously, this concept we try to translate in the human, and so the real-time digital replica, a physical patient that evolves based on incoming data. So this is extremely important to have a duplication of the body, not only under the anatomical point of view, but as well under the biological point of view, because we need in the next future to have the copy of the single body in order to obviously to predict the analytic aspect and in order to enhance decision making. This is extremely important. How to create the human digital twin? So we need to have some, first of all, some data. From data that are represented by imaging, MRI, CT scan, genetic profile, physiological data, we can create with computational analysis and artificial intelligence, we can create obviously the model, and obviously this model we need to be continue updating because as you know the body evolves, we have a new disease, we have problems during the day, and so we need to have an upcoming of adjourn of this of the data for each patient. So the role of digital twin in healthcare can be obviously have different application in a diagnosis, early diagnosis of detection and progression modeling, for treatment planning, for surgery, for example, for virtual preparation of surgery, and to obviously have the remote patients monitoring. So it's extremely important considering the cost of healthcare. I think that in the next future will be another field of application of this type of field. So, as you can see, we can apply the digital duplication as well in medical oncology. This is one virtual model in which inside the cells and the tissue tumor, in which there are an integration of genetic, molecular, and clinical data, well, we can test the efficacy of the drugs that were you applied for the management of the special single tumors. And so we can test the drug before give this drug, apply this therapy in the single patients. So this is extremely important because it can save, obviously, a big amount of trials. We can prevent the results before doing the trial in phase 1 or phase 2. So, but we have obviously the possibility to use this technology as well in surgery. How we can apply it? First of all, we can create obviously the duplication of the organs, and so we can predict, for example, with artificial intelligence, we can predict the behavior that the tissue have during, for example, during surgery. And obviously we can apply the virtual reality integration, allow the surgeon to practice the procedures before doing the operation. So the advantages are extremely important to reduce surgical errors, enhance precision, and provide obviously a training tool. So I try to focus on surgical scenario because we have a little bit of experience about this. As you know, in the past, we have already integrated inside our modeling the functional aspect, because we have segmented already the single area of the tumors, and so we can see what is the erosion of the single area, and at the same time we notice what is the renal function and the consequence of our surgery, because we clamp the single branch, or we clamp we can do the global clamping. And so thanks to this segmentation, we can analyze precisely the impact, positive or negative impact, in terms of renal function. So, but there are some pitfalls, because obviously the anatomical aspects of the organ are not similar, as you can see, with the real organ, because in the upper part of the screen we have the real organ, in the lower part we have a superimposition, augmented realities, but as you can see, when we have the transparency, thanks to the transparency, we can see in the tumor inside, but the anatomy is not similar. So we have only a morphological representation, but it doesn't appear with the same anatomical characteristics. At this point, our idea is to duplicate the organ, and the organ should be quite similar to the original organ. So the objective is to maximize the visual concordance between the virtual organ and the real one, and so we start from this anatomical representation of the body and what we have done. So, first of all, we think that it's extremely important to have a 3D model that, as you know, is composed by independent parts have dependent elements, like the seminal vesicle and as well the prostate, and so we can capture the different specific texture produced for each them selected intraoperatively, and we superimpose the texture oriented on the basis of characteristic of the organ. And so with these three steps, we can create one organ that is completely similar with the prostate, original prostate. Well, this is the final temporary products. Why the temporary product? Because, as you can imagine, we can enrich, we can add other information. So, what are the information that we'd like to add? Obviously, the functional aspect. So this organ can be obviously employed for in the metaverse setting. Look at the organ is quite similar. We can use the transparency. It's the first time that the twin can be segmented, so you can see the anatomy, the details of the anatomy inside the organ, and we can share obviously our idea, our planning with other surgeons. But there are some issues. The first issue is represented by the tissue texture selection. We need to select the best texture because we want to duplicate the same organ. The second aspect is represented by the lack of natural elasticities. We have not taken sufficient elasticity. We have the rigid organ. And obviously, when they have a lack of biological data like tumor necrosis, functional renal function, and other aspects. So what and how we have done to solve this open tissue? And I think that we can apply the artificial intelligence for producing exactly to choose the proper texture, to choose the organ elasticity, and to add the biological data. Well, so look at artificial intelligence now can be employed for selecting the best texture, because first of all we can apply, we visualize the images, we tag the single images, we can learn the algorithm, and after the manual tagging the first step, and secondary, in the second step, there is an automatic selection by artificial intelligence. Obviously, with the aim to generate one custom texture for each single patient. And second aspect, the second aspect is the application of elasticity. There are new software that they are able to reproduce the elasticity for each organ. This is the kidney. As you can see, we have a different elasticity, but we need to adapt the elasticity at the single organ. And so at this point, we try to experiment to do the application to evolve with our software in vitro, inside in the lab, in order to create the realistic deformation. And so the deformation are quite similar, and now I show you how we can create this modeling. Look at, we are inside the kidney on the right side, and so we can have the movement as well of the calyx and as well of the single artery of the single vein. Well, what we have done is extremely easy because, as you can see, we have different elasticity of the bladder as well as of the prostate. During the operation, we try to classify the different elasticity in 4 degrees. We transmit this data to the artificial intelligence, and well, the artificial intelligence that is applied in the software with this algorithm is able to deformate, to give us the possibility to have an elasticity that is adapted at the single organ. This is extremely important. So, but we need to add as well new biological data. How we can add biological data? It's extremely easy. It's enough now in this step to acquire information about the necrosis of the tumor, the surface, the size, etc. And so we can add this information with artificial intelligence, and at the end, when create, we can add not only the elasticity, but as well the information about the characteristics, the tumor characteristics. So, at the end, now the conclusion are the following. The digital twin promises improved surgical accuracy and tailored oncological care, support adaptive treatment and patients monitoring, but I want to underline that it is still in its infancy. More research needed to accurately reproduce all organs in the near future. Anatomical and functional aspects have to be integrated, and it's important to improve our knowledge in terms of elasticity, tissue texture, the biological data, and obviously these elements could be all integrated in one physical and digital aspect in order to create the phygital twin. So it means the physical organ inside one virtual reality. Thank you so much.
That's amazing, Professor Porpiglia. You're taking imagination and really making it in near reality. So we're really looking forward to the next steps there. If I can ask our final 2 speakers to try to keep your talks to within maybe 10 minutes each, if that's possible, just so that we vacate the room. Come on up in time for cocktail hour. So.
Hi everybody. Firstly, let me thank Dr. Bandari and Mr. Vatticuti for the kind invitation. Actually, I was asked to prepare a 5-minute presentation, so I will be on time. Today we'll complete the speech from Professor Porpiglia, talking about the concept of anatomical digital twin and our preliminary study on it. So, as Professor Porpiglia already said, we are essentially working on 2 different pathways regarding the 3D virtual model. The first one is functional. So we are trying to add as much functional information to our models to have this. We gain a very high experience in the in the functional building of the virtual model. We developed model that can predict not only the vascular anatomy of the kidney, but also we move forward in the last year, having new information, such as the percentage of parenchyma perfused by each single artery branch, but also the prediction of how much healthy tissue we will lose according to the resection technique that we employ, and also the contact with other anatomical structure like the collecting system. But the second pathway is the anatomical one, because we do not only need the anatomical the functional information, but also the model should be as much similar to the anatomy, the surgical anatomy, to let, especially novice surgeons, to find in the real operative field what they will exactly see. So, in this sense, we try to use, to translate the concept of digital twin, which is mainly used in the industry and the manufacturing, and we try to translate it on the anatomy. So, in this sense, we developed the anatomical digital twin, and in this case, we tested it on the renal surgery. The aim of our study was to develop the anatomical digital twin of kidneys with its tumor, and to test their role in surgery during robotic-assisted partial nephrectomy. For this study, we enrolled 2 surgeons, a young surgeon and an expert surgeon. Here is how to develop you can see how to develop a digital twin model. So, firstly, we use 2 softwares. The first one aimed to adapt the 3D virtual mesh on the shape of the real organ, and the other software recognized the texture of the organ, so the kidney and the other structure like the pedicle and the tumor, and find the texture of each element, and then the other software adapt the virtual mesh on the organ. So the surgeon could, during a robotic radical partial nephrectomy, they could consult both the models, the standard model and the biodigital twin, during each phase of the surgery. So for the kidney isolation, the tumor isolation, and pedicle dissection, and the ureter identification. We use a 10-point Likert scale questionnaire to assess how these models concord with the real anatomy and the usefulness in identifying intraoperatively the kidney, the vessels, the tumor, and the ureter. We enrolled 4 patients, 2 with low aggressiveness, low complex kidney tumor, and 2 with an intermediate complexity kidney tumor according to Padua classification. The 3D anatomical digital twin was found to be superior to the standard digital twin for the concordance with the real anatomy. In terms also of usefulness, in identifying not the kidney, not so much the kidney, but the tumor, the vascular pedicle, and the ureter. And the gap was even higher for the novice surgeon. So we can say that the anatomical digital twin represents another step forward towards a personalized virtual reconstruction of the organs. This showed to be possible to have a possible higher degree of concordance with the intraoperative environment, making it easy to recognize the organ inside the real surgical field. But in the next future, we should walk in the same pathway, not two different pathways to improving the anatomical features and improving the functional features, but combine all of this information. So combine the anatomical information and the biological information of the organ, of the tumor, especially the histotype, and also the virtual model of the future should suggest the surgeon which surgical strategy should be the best for that specific patient. Thank you.
So, Professor, what do you feel like? I think the imagination is rich, the vision is clear. The limitations for the digital twin, is it technological? Is that our constraint? Or what is our constraint to have it in every operating room today?
So, first of all, concerning the reproducibility of the 3D modeling in terms of twin is extremely difficult nowadays because we not have sufficient technology, because we need in the next future to have an automatization of this type of reproduction. And so I think that we are working in order to reproduce exactly in a short time, not in a long time. Up to now, we need to have the engineers that take the copy of the single parts of the surface of the kidney and to orient in the shape, in the real life, like we see during the surgery. But in the near future, I think that is possible, thanks to the acquisition of many images, to do it automatically in a short time. What is the advantages? The advantages in comparison, the rigid system, I think that could be the elasticities. Because, as you know, when you use the augmented reality, so the doctors that they help me usually need to adapt the 3D modeling at the kidney, at the surface of the kidney, and usually the adaptation is based on the zoom, and so we need to extend and reduce the images of the 3D modeling. Instead, with the elasticity, I think that you can adapt better. Moreover, don't forget that usually we see and we adapt the 3D modeling when the kidney is in a fixed images. So one is dissected completely in anterior phase, and so we can have an overlapping there. But as you know, when you do surgery, we move the kidney, we dissect the kidney, and so we need as well to see the posterior phase. I think that thanks to the elasticity, so we have the possibility to follow this the movement of the surgeons, and so we can see better, analyze better the posterior face of the kidney, the upper pole, the lower pole, so all details, not only the anterior face of the kidney. Moreover, we in the near future, I think that we need to have the 3D images of this reproduction, of this 3D modeling. If we have a 3D vision as well, like with the 3D vision of during the robotic surgery, perhaps that we have more details and we are more precise in overlapping.
We need more twins of you in the world to dream of these visions.
Yes,
so.
we have a lot of work for the near future.
Great. Well, thank you very much. One last question for the audience.
I think, first of all, thank you so much for the wonderful presentation. I just have one question. When you talk about the digital twin, where you're talking about the texture, the feel, is it possible to get biopsy tissues,
Yeah.
normal,
Yeah.
a bit of normal, and the tumor?
Yeah.
Age, sex, I mean, of various ages and sexes, and get, apart from the routine histopathology, also a study of the physico-chemical properties of the tissue.
So when we are working in this sense, we are working in this direction, and so we have more than 2,000 cases of CT scan, they are recorded, And we are obviously the histological examination, and we have the 1,000 3D reconstruction.
So that
So
will probably help.
now we try to combine all details, not only histological examination, but as well like on the characteristic of the patients, biometric characteristic of patients. And now the next step on the work will be this one. So to establish it, if it's possible, like, define the nature of the aggressiveness of the tumor based on the morphological characteristic, but as well what is the impact of renal function and the characteristic of a normal tissue, of the healthy tissue, based obviously on the characteristic of patients like BMI and the hypertension, etc.
Perfect. Thank you.
Thank you very much. With
Thank
that,
you.
we'll close the session with a few minutes to spare. Thanks, everybody, for your attention. It's been a very inspiring afternoon and really a pleasure to be here on its opening day for the symposium. Thank you.